This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews.
At the 3-week mark, I get a notice in my inbox from the inpatient attending. I am sorry that your patient did not survive. This week on Clinical Correlation, the Optimism Bias.
And welcome to episode 57 of Blood and Cancer. We got past 1 year, our 1 year anniversary 2 weeks ago. We are chugging right along with our conversations that were recorded at the 2019 annual meeting of the American Society of Hematology in Orlando, Florida. And I'm joined this week, as I always am, by Dr. David Henry. And Dr. Henry, I guess our topic this week is something that the University of Pennsylvania knows all about, which is who you're affiliated with. That's CAR T-cell therapy.
Yes, it's on the subways, the buses, and the taxi cabs. And the first commercial on your screen each night of the news, it's everywhere in Philadelphia. It's almost true because it's so popular and so effective in some patients. And we're going to talk about it today with a doctor from Cleveland, of all places.
Absolutely. So we'll get a little bit more into what that conversation is all about. But let's start with clinical correlation this week. Dr. Ilana Yurkiewicz, after the conversation, clinical correlation. The topic this week is pretty interesting, I think, as it always is. Optimism bias, and when a patient is sort of striving for optimism, the fine line of making sure you convey facts and tell the truth, but also perhaps allow the patient to be optimistic for their goals of care.
I think it's an awfully good topic, and Ilana does it so well. I actually saw a patient today, small cell lung cancer, which we know is bad. It initially responds, and then it starts to get resistant. And I sat with this patient today. He was by himself, and he's had about 8 cycles of therapy, and it's starting to not work. And, I can look at him and think to myself, well, this man's not likely to see the end of this year, and really crash his world and say awful things to just ruin the next minute, hour, day, week of his life. And without lying, I think Ilana will cover well, I try and hold out as much hope as I possibly can to help him win or lose with the cancer. I can help him, and I will develop another option if at all possible.
And I think that that's such a important part of therapy is, I guess, the mentality of the patient. If for nothing else, to have some clarity and some honesty and a reason to sort of, I guess, exist for the final years. And I guess that it gets to be a really heavy topic. But once again, such a fine line that she seemed to unearth, and it's a really great rendition. Of course, that's coming up after our conversation. Doctor this week is Allison Winter. She's from the Cleveland Clinic. We're talking, as we mentioned, about CAR T therapy and its uses in lymphoma.
It's an incredible development. So chimeric antigen receptor T cells, you basically say you've got a patient with an army of, in this case, T cells that wants to hurt the tumor, but just not doing it. You've got a tumor which is suppressing that army, and the tumor's winning. So you take some of the army out, you take some of the tumor out. It's specially processed, often off-site, often another city, depending on the product and the university doing it. And you essentially make that army really attack, in particular, the specific tumor to which this patient has by especially developing these chimers, or part antibody, part T cell, part go after the tumor, part bring the T cells to the tumor, and then you infuse it back into the patient. And it many times, where before we had not much except second, third, fourth line chemotherapy and not working, it develops some phenomenal responses that can be very long lasting.
So throughout your career, when this therapy was developed, what was it like when it first got out of the phase 3 trials and really started to have a clinical application? What was that like when that happened?
Well, it was really exciting. And part of the excitement of being in hematology oncology is the science, the so-called bench to bedside, is really showing us the way and shining the lights where we didn't have before. And these patients, diffuse large B-cell lymphoma, higher grade lymphomas that relapse, and we do stem cell transplants, either auto, allo, and hope for the best. And now this takes the patient's cells, the tumor, processes them, as I've mentioned, and it generates responses that you never saw before. I think one of the challenges we'll get into in our interview is who should get this. You advertise this, of course, so all the patients call and say, oh, I want CAR T. well, maybe it's not for you, depending on your tumor and what's happening. How is it done? You have to be able to survive a couple of weeks while the product is developed. And so waiting.
That's a really interesting part of this. Yeah, I remember that part of the interview. That was something that I hadn't thought about before. You have to make it to the fact, you have to wait for it to exist first, and that can be kind of tricky.
And not all patients do. Sadly, the tumor takes over, the disease takes over before the product is developed and can get back. And so the careful criteria developed by all CAR T clinician scientists like Dr. Winter to get the right patient and get the right situation and get it into them.
And of course, Dr. Emily Breyer, author of our show notes. There are robust show notes. Those have links and an outline to what's talked about in the conversation. You can also find links to Dr. Ilana Yurkiewicz and some of her writing in the show notes as well. Wherever notes are found in your app, you can find more hematology and oncology news and information at mdh.com/hematology and oncology. And as we record this in the second week of February, I do have the most important question before we kick it over to the interview, which is, what is your advice for what to get significant others on Valentine's Day?
Something they'll really love.
Something they'll really love. That sounds like a man who's been happily married for quite some time.
Yeah. Good luck with that.
Groundbreaking.
All of you listening, hope you did so or do so.
Guideline-changing advice from Dr. Henry right there.
Exactly.
All right, so let's kick it over to our interview with Dr. David Henry and Dr. Winter. Don't forget to stick around for clinical correlation coming up after.
Thank you, Nick. See you next week.
Welcome to this podcast. I'm Dr. David Henry. You're listening to Blood and Cancer, the weekly podcast from our online journal, mdh.com/hematology-oncology. And we try and bring clinically relevant for practicing hematologists, oncologists, issues each week about what's important and what may be useful in the clinic. And I'm delighted this week to be talking with Dr. Allison Winter, who is at the Cleveland Clinic, and a rather new young staff lymphoma expert. Allison, thanks for stopping by.
Thanks for having me.
So you have expertise that most of us don't have, which is in this thing called CAR T therapy. And so I'm thinking as a practitioner, I have, for example, diffuse large B-cell lymphoma, and he's had first-line therapy, and sadly, 7 months later, maybe relapses. And I wonder, should I call you now? And it's a rather advanced disease, maybe 60 years old, not too much in comorbid illness, but clearly relapsing. Do I call you then? Do I call you after I've given something to induce some kind of response and then call you? So where do you want the calls to come from, and when should I refer this patient?
That's a great question, and I would say the time to refer the patient is at the time of relapse, because not just for CAR T-cell therapy, but for other clinical trial options. So
of course, yeah.
The standard when you relapse with diffuse large B-cell lymphoma is to go on and receive salvage chemotherapy, and then if you have chemosensitive disease, to go on to receive an autologous stem cell transplant. But we know from the CORAL trial that our salvage chemotherapies aren't perfect, and you can't benefit from an autologous stem cell transplant if you're not chemosensitive to salvage therapy. So there are a lot of exciting clinical trials available at this salvage chemotherapy setting. And then there's newer clinical trials coming out looking and comparing CAR T-cell therapy, which is currently after auto transplant, or if you're refractory where you can't get an auto transplant, and comparing CAR T-cell therapy at that point versus an auto transplant. And for some of those trials, you have to be randomized before even receiving salvage chemotherapy. So the sooner the better.
Well, I think that's a great answer. I think of, in my question to when to refer, you're going to need this patient's army of T-cells to be somewhat alive and well. So if I have the patient relapse and give a relapse regimen, which probably has a small chance of working indefinitely, and then a stem cell transplant, that's going to have an induction regimen, I may be exhausting these T-cells, which you need when you do CAR T. So if I understand, it sounds like you're thinking in a clinical trial of taking this patient either perhaps to a stem cell transplant or CAR T and move it up earlier.
Yeah, so just like most of the oncology world, when we find something successful, we try to move it up and up and up and closer to first line. So the ZUMA-7 trial is comparing auto transplant versus CAR T-cell for the first relapse, whereas right now CAR T-cells are approved after 2 prior lines of therapy.
So that's the approval. Mm-hmm. Well then, all right, so I've made this referral, you've taken this patient either for clinical trial or had 2 relapses, hits the FDA approval for a CAR T. Now, I'm not sure what happened. So the patient goes to you, and you sign consent. The patient's going to go on CAR T. what happens next? I know it doesn't happen right away. There's some product preparation. So could you walk us through from first visit in the office to when the patient's admitted for the CAR T reinfusion?
Yeah, so it's a long process, probably more so for the patients and the families than for us. But the first step is we have to evaluate them and say, yes, this is appropriate. And the next step is writing the letter to get approval from the insurance process. And then once we get approval from the insurance process, then we can actually collect the patient's T cells. And then the T cells have to go off for manufacturing, which can take several weeks. And then they get shipped back. Patients get lymphodepleting chemotherapy and then admission to the hospital for the infusion of those CAR T cells.
What's that period of time, do you think?
So there was an abstract presented at ASH last year looking at the real-world data with one of the commercially approved products, Yescarta. And I believe they reported the median time from to get the CAR T cells was something like 26 days.
Okay. All right. So, yeah, I had in my head 3 weeks, so it's about 3 weeks. Maybe we're trying to do better. Now, I hear you say once about off the shelf. Is there some way that the product might get to you faster, it's ready to go? Or did I misunderstand?
So right now we're using in commercially available products are autologous T cells, so the patient's own T cells that have been genetically modified. In the future, clinical trials will be looking at like off-the-shelf CAR T cell products, allogeneic CAR T cell products. That's much more in the future.
Allogeneic, I see.
Yeah.
So it'd be ready to go. Just try and match as best you can like we do with transplants now.
Yeah, so that's very much in clinical trial stage.
Well, in the future, it tends to be 2 years away, and it comes up faster than you think.
Yeah, but it's an interesting concept because some of these patients, when they need CAR T cells, they need it ASAP,
fast, yeah.
And we have to do things like bridging therapy. And for instance, I just had a patient, she's 30 years old, she has primary mediastinal B-cell lymphoma, and I gave her the standard salvage chemotherapy, and her large mass in her chest grew after the salvage chemotherapy, and we needed CAR T cells fast, and we ended up having to radiate some sites of disease to get her
Keep her
to the process.
Enough, to get her product. Well, now, I think another thing we generalists think of when referring to you for this is you've seen the patient, appropriate for CAR T, gotten the product, given it to the patient, and the patient admitted, and maybe disappear for 2 months is our thinking, but that's not always true. What then happens in terms of the range of adverse effect, the good, the bad, what are you seeing?
So I think a few years ago, especially when I was in training, I would hear patients hear immunotherapy and think, oh, it's no big deal. It's not chemotherapy. They'd seen either their parents or grandparents, puking and losing hair, and they have all these negative associations with chemotherapies. This is fine. And that's not the case. There are several side effects, adverse events that can happen that are very serious to our cytokine release syndrome and neurotoxicity. And when patients actually hear about this in consultation, it can be really scary, especially the 30-year-old I just mentioned, when she heard about potential neurotoxicity, being in the hospital and not being able to say, this is a watch on my wrist. That's really scary.
Yeah, the cognitive malfunction. Is that, I heard back a year or two, was rather common. Who they are, where they are, that were confused, didn't know in the ICU. Is it as common or less common now?
So that is a complicated question, and part of that has to do with the different grading systems that have been used. So we have 2 commercially available products right now, Yescarta and Chimeric. And the clinical trials that evaluated these products, there were different grading systems. So it wasn't until 2018 where the American Society of Transplantation and Cellular Therapy said we need to have consensus criteria to grade cytokine release syndrome and to grade neurotoxicity.
Which is now one grading system that
so now there's consensus that we are using going forward, and that will help us compare some of these side effects, which can be variable from product to product.
Well, I think that covers everything I wanted to ask. Typical patient, whom to refer, when to refer, what the timing is, and then the possible side effect. Anything else you wanted to add about the CAR T experience now that you're going to write the future textbook?
It's at a very exciting time in oncology, and I think we're getting more comfortable with it. One of these intense therapies that we use when someone does develop cytokine release syndrome, tocilizumab. I think initially there was some hesitation to use that because of the potential the potential effect on efficacy. And now that we have some data saying that it doesn't impact efficacy, we're using more toci. So it'll be interesting to see how that will affect the actual numbers in terms of these.
So it's used more commonly now, and
we're going to it a lot faster than we used to.
Well, I want to thank you so very much. I've been speaking with Dr. Allison Winter, new wonderful young staff lymphoma specialist at the Cleveland Clinic. You've been listening to Blood and Cancer, the online journal mds.com/hematology-oncology. There'll be show notes each week on that webpage if you want to see the bullet points of what Allison had to say. And we thank you very much for listening.
And that concludes the conversation portion of our show this week. Don't forget, you can find robust show notes available wherever notes are found in your app. When we come back, it's Clinical Correlation with Dr. Ilana Yurkiewicz. Welcome back to episode 57 of Blood and Cancer. I am Nick Andrews. It's time now for Clinical Correlation.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. There are many well-known cognitive biases in medicine. One we see in oncology is the optimism bias, when you believe you're less likely to experience a negative outcome. It applies to patient thinking, but it also applies to physician thinking. Especially if you like your patients and have a personal connection with them, you're more optimistic about their outcomes. Recently, I've been reflecting on a conversation I had a few months ago with a new patient in clinic. He had presented to another hospital with an infection, and a CT scan showed he had extensive cancer throughout his abdomen, pelvis, and lungs. Biopsies confirmed it was all an aggressive metastatic sarcoma. He left the outside hospital even before his infection resolved in order to make his new patient appointment with us at Stanford. When I saw him in clinic, he was clearly not doing well. Besides the cancer, he was still septic and needed to go back into the hospital. But he and his wife wanted answers about his cancer, this horrible burden that had been suddenly and unexpectedly thrust upon them. I wanted to be honest about how serious things looked. I did tell him it was metastatic, it was incurable, and that we had treatments to slow down or halt its growth. But he kept pushing. It's treatable, right? We have something, right? I told them yes, to their obvious relief. I then told him he would need to go back into the hospital to deal with the infection. How long, they asked. Until it's resolved. Probably a few days to a week, I said. I followed along his hospital stay. At the 3-week mark, I get a notice in my inbox from the inpatient attending. I am sorry that your patient did not survive. A palliative care doctor once gave us good advice about when to address end of life. They said if you wouldn't be surprised if you heard that your patient died within a year, now is the time. When I met this man in clinic, I would not have all been surprised if he passed away in the year. But it was our first visit, he was overwhelmed, he was reaching for optimism, and I gave it to him. I've been thinking about that conversation since I heard that he passed, and I wonder if I should have been more honest about my fears. At the same time, I think, why? They had plenty of conversations in the hospital as things evolved. Why should I have taken away hope, given all the uncertainty at the first visit? Optimism in cancer is a complex subject, and I don't want to simplify it in a few minutes. I will say, though, that I too am susceptible to the optimism bias. When I counseled him that first visit, I thought of the most optimistic version of his future, and I shared it. I don't think it's necessarily wrong or dishonest to be optimistic and hopeful. But I do think we should be actively cognizant of it, so we don't lull ourselves into false hope just because we like our patients. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And a big thank you, as always, to Dr. Yurkiewicz for the human side of hematology-oncology care. That concludes episode 57 of Blood and Cancer, the official podcast of MDH Hematology Oncology. Let's get to this week's credits. Blood and Cancer is produced and hosted by the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. Clinical Correlation is written, recorded, produced by Dr. Ilana Yurkiewicz. Blood and Cancer is produced by MDH Hematology Oncology editor and executive editor, Mary Ellen Schneider. All MDH podcasts are produced by our editor-in-chief, Dr. Ivan Oransky, as well as executive editor Kathy Skarbeck and multimedia editor Terry Rudd. The show notes this week were authored by Dr. Emily Breyer. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDH podcasts, Nick Andrews. You've been listening to Blood and Cancer.